Simply put, right? No man should ever have his prostate biopsied. That's my position, and it's based upon my research and clinical experience. So bear with me. I'm going to explain a little bit over the next few minutes in this podcast how to manage an elevated PSA. This is a horrible black hole of uncertainty, fear, and misdirected therapy. In medicine, we do things largely out of inertia because it's the way we always did them. Think about prostate cancer, the history of it. It was in the 1950s when removing the prostate gland became the standard of care. Now, bear in mind, back then, no PSA test, no Gleason score, rectal exam, nodules, prostatectomy, or maybe a biopsy. 1960s, this became widespread standard of care. Well, in the face of removing prostate glands to prevent death from prostate cancer, it would have been logical to expect that the death rate from prostate cancer would decline in the ensuing decades. But from 1960 until 2000, the death rate per capita actually went up. Beginning of evidence that, hey, maybe what we're doing isn't so cool. Now we've got a circumstance where they discovered the PSA. It was the 1990s. We've got a blood test, the prostate-specific antigen, that can measure a specific protein that is largely manufactured exclusively in the prostate gland. And it goes up as we get older. Almost always, the prostate gland will get larger as men age. That's pretty universal. And as it gets larger, the PSA level tends to creep upward. The PSA level can also go up in the face of prostate cancer. However, an elevated PSA is not a diagnostic test for prostate cancer. And yet, it has acquired this compelling status that somehow we can predict based upon the number. We can't. A PSA that is elevated could be benign. A PSA that is low could be present in the face of a cancer. So we're left with a bad test without specificity. Well, so imagine you're a man of a certain age, maybe in your 60s, 50s, your PSA level is above a magic threshold. The threshold is arbitrarily assigned. It is the best guess. So the momentum builds, right? If we take out a prostate gland, it must be good because we can prevent cancer. Here's the problem. Prostate cancer, the 5-year survival rate from prostate cancer, if you do nothing, it's like 99%. The 5-year mortality rate, the death rate from prostate cancer is practically zero. So anything that is done has the appearance of being effective. You take out the gland. 5 years later, no cancer happened. You pat yourself on the back for a job well done. Saved a life. Now, if I'm the patient and I just went through a horrible surgery that left me leaking urine, that left me impotent, I have to believe it was worth it. I have to believe it saved my life. It's the only way you can justify such misery. How about if the presumption is false? What do we know about prostate cancer? In the 1860s, the first prostatectomy was performed, one of the first in the modern era, in England. And at the time, the surgeon said, this is a rare disease. Rare? What happened? How did it explode? I believe that it's a misidentification. Prostate cancer is not one thing. There is prostate cancer, and there is dormant atypical cells. Call them DACs, dormant atypical cells. These are weird-looking cells that live inside a prostate gland, and they look kind of like cancer. They're just kind of weird-looking. But they're not cancer. Two different diseases being lumped together. And because of this lumping, too many men are getting shuffled into traumatic treatments with very little benefit. So the PSA test shows elevation. Next step, hey, let's do a prostate biopsy just to be sure. You take a perfectly healthy man with no symptoms to speak of. Yes, I understand the prostate gets bigger, and with that, there could be hesitation of urine flow. There can be waking up at night to pee. There can be urgency. Hey, I gotta get to the bathroom in a hurry. These are not symptoms of cancer. These are symptoms of prostatic enlargement. In the setting of such symptoms, a PSA study can be done. It's not unreasonable to do the study. The problem is what comes next. They recommend a biopsy, so think about what you're doing. It's not a simple, targeted, singular needle stick. There are at least 12 of them, and they're not needles, they're core biopsies to get tissue out of the gland. 12, maybe more. They hurt. You'll have bleeding, pain, feel bad, infection can happen. And on top of all that, if it comes back negative, you don't know if they just missed cancer, and you don't know what's going to happen in 6 months or a year. So you're still in a very stuck place. Suppose, on the other hand, they jab that core needle into a nest of prostate cancer cells. There's a possibility that harm could have been done, that you're disrupting cancer cells that are best left dormant. And now you just stuck a needle in there or a core biopsy in there, creating blood. Cells can scatter, they can metastasize. Now, doctors do not like to contemplate the possibility that what they're doing could cause such harm. In fact, there are very few studies looking at this issue. Nobody stands to gain anything from such a study. None of the people that make the core biopsy, none of the people that make the Da Vinci machines to take out prostate glands, none of the doctors who do the procedure. There is no vested interest behind a study to determine if these biopsies can spread cancer. And yet there's evidence in the literature. And it comes actually from the breast cancer literature. In one study, they looked at women who had high suspicion mammograms. And half the women had a biopsy first, and the other half went directly to a lumpectomy. The women who had the biopsies had a high rate of subsequent metastatic disease. Interesting. Another study where they had women had needle biopsies, subsequently had a mastectomy when they found cancer. And they looked at the breast tissue in the pathology suite, and they found needle track evidence of cancer cells along the needle track. So there is evidence of the possibility of cancer spread from sticking needles in there. Now, sometimes you need to put up with a risk to get a benefit. But here's really where the whole thing kind of falls apart. After years of study, we now have some outcomes. There was a study published in the New England Journal looking at 2 groups of men. They all had, actually 3 groups. All of the men in the study had prostate cancer. One of the group had their prostate gland removed. Another had radiation therapy, and a third had nothing done. Gland removed, radiation, nothing. What they found was, after 20 years of observation, the same death rate from all causes and the same death rate from metastatic prostate cancer. How could that happen? If the guys had their gland removed, how could they subsequently die from metastatic prostate cancer? The answer is cellular metastatic process. The leaking of some cancer cells into the system that allows them to become implanted. That's a problem. But what's a bigger problem is undergoing such an aggressive treatment with the false impression that it's going to cure you, and it has no benefit. At least when you look at the studies, you look at the outcome, why are we still doing this to people? Wouldn't you look at that result and say, oh, time out. We need to rethink the whole equation. Well, there is some reconsideration underway, but it's not that impressive to me. So now instead of taking out the gland in some cases, they'll do what's called active monitoring. This is when they do biopsies at staggered intervals. This, folks, defies logic. We're doing these biopsies to see if the cancer is going to change. And yet, there's nothing about a biopsy that can predict the future behavior. You can't tell from looking at a biopsy whether or not cells have left the gland. As long as the cancer cells sleep in the gland, you can never be harmed from prostate cancer. Dormant atypical cells sleep in the gland. Cancer moves outside of it. When that happens, you got bona fide prostate cancer worthy of consideration of some types of conventional therapy. However, if all you have going on is an elevated PSA and a funny looking prostate, but you feel great, let those cells sleep. They're not going to harm you unless they leave the gland. Now, the approach at intellectual medicine is to create an inhospitable environment toward cancer cells. There are things that can be done that'll lower the cancer risk or the risk of metastatic spread. There are things called repurposed drug therapy. This is when we take drugs intended for other purposes, but have been shown to have anti-cancer attributes. Inexpensive, generic, very safe, no surgery, no biopsies. An MRI of the prostate can be performed. This will reveal the risk factor for cancer to be present. And it can be used to follow the course year over year. So instead of sticking needles in you, we can do an MRI and see if there's a change year over year. PSA level goes up slowly. The MRI looks unchanged. You ride that wave. You don't go about sacrificing your manhood, sacrificing your virility, sacrificing bladder control. This is an unpleasant path. And I don't care how much they try to minimize side effects, they're real. And there's no way to guarantee they will not occur. Not to mention the collateral damage, infection, blood clots, heart attacks. Studies looking at non-cardiac surgery in patients over 65 had a significant portion of them developing silent strokes. That's when the damage to the brain occurred without symptom. And a year later, there was cognitive decline. So there are a lot of reasons to avoid intervening, especially in the face of such data showing the null effect. If you're going to go through something horribly traumatic, if you're going to go through something that compromises your health, there better be a big win at the back end. With prostate cancer, that's not the case. So how does this keep going? Because of all the testimonials, right? Some celebrity has prostate cancer and says, oh, thank God they took out my gland. They saved me. Well, another way to look at prostate cancer is following the men who have prostate cancer and ultimately die. In one study, they looked at that arc. Over 250 men with prostate cancer ultimately died in this particular study. Of those 250 who died, roughly 17 of them died from prostate cancer. What did they die of? Heart disease. It may well be we're barking up the wrong tree. I had a patient who came to me with a prostate cancer demonstrated on a biopsy. Very concerned. Young man was in his late 40s. Justifiably concerned, and yet in the dilemma of what to do. So in the course of evaluating him, we did a calcium score. It's a CAT scan of the heart. He had severe calcified arteries. He was not destined to ever die from prostate cancer. He was destined to die from heart attack. Therefore, we were able to focus on both avenues of treatment. The paradox, one of them is, if you die from something other than prostate cancer, the oncology, urology team can kind of consider that almost a success. After all, you didn't die from prostate cancer. So how do we treat prostate cancer? We take out glands, we irradiate. Two bad things. So I already told you to take out the gland and the consequences from infection, blood clot, heart attack, postoperative complications, up to and including death. leaking urine, and impotence. This is not a good deal. Well, how about radiation, right? That seems more gentle. Problem: does nothing to prevent future death from prostate cancer based upon available data. And it has a delayed negative effect. Radiation proctitis. You irradiate the prostate, the surrounding tissue gets hit as well. And 5-10 years later, the rectum becomes stiff and friable. It can break down the tissue. You can have blood in the stool. You can have leaking stool. And there's no treatment for that. When radiation has damaged tissue, there's really very little that can be done to retrieve and recover it. If it happens in the bladder, you get radiation cystitis. The bladder gets stiff. You can leak urine. You can have bloody urine. As if that's not enough, whenever you get radiation therapy for cancer, any cancer, but prostate included, your risk of subsequent leukemia, lymphoma, and solid tumors goes up. Lifetime risk, delayed effect. So think hard before you push the button for treatment. Think hard about alternative pathways. One of the problems that we have in medicine is a tendency to be a little bit dogmatic and a little bit almost coercive, guiding patients toward a treatment when really we only have one note on the piano. This is a great space for intellectual medicine. It's a great space for the avoidance of trauma, for the intervention of things that can help make us resilient. After all, what stops cancer from getting metastatic? What stops cancer cells from growing up into tumors? Our immune system. A lot of different risk factors for cancer, but you know what the biggest one is? Age. The older we get, the greater the risk. Several reasons that could be. One, the immune system tends to weaken. All right, so let's do things to keep it strong. Certain supplements may have value. At Intellectual Medicine, we even have infusions to help support that activity. The other possibility is gradual exposure to accumulated toxins. Carcinogens are dangerous. They're more dangerous when they're close to us, right? I don't worry too much about Chernobyl. I think it's bad that it happened, but it's not going to affect me. I had my house tested for radon gas. That's where I live. I had my body tested for cadmium, a powerful carcinogen that we all have buried in our tissue. It's a polluted world. We absorb it from the air, the water, the dirt, lead, arsenic. These are carcinogens that are inside us. Guess what? We can measure those, and we have a means of helping to extract them safely with oral capsules. So we create an inhospitable environment. Percent body fat correlates with increased prostate cancer risk. Really, all cancers go up as a percentage of fat goes up with it. So let's get down to the cellular level. Let's make the body inhospitable toward cancer. And you get the bonus effect when you do this intellectual medicine approach. We're going to be supportive of immune function, using some oral supplements. In many cases, infusions may be a part of that, vitamin infusions. Then the repurposed drugs. There are several that I really love. One of them is sirolimus, also known as Rapamune. This has an ability to interfere with cellular degradation and support mitochondria, the hub where a lot of cancer tends to occur. Low-dose naltrexone has been correlated with a decreased tendency for metastatic spread. Low-dose doxycycline actually can interfere with stem cells from the cancer. And DMSA, dimercaptylsuccinic acid, a compounded FDA-approved capsule, can pull out those toxic carcinogenic elements from your body. You put this together, not only do you avoid the trauma of surgery, but you can do something proactive rather than passively waiting and hoping. The concept called watchful waiting, the art of doing nothing while you observe to see what happens next. Hey, at least it's better than having surgery or radiation. At least you're not going to harm people. So let's try to get off this treadmill. The book I'm writing, it'll be out soon. Hang in there, it's coming. Explains all this in detail with references. part of the challenge that we have is breaking the inertia momentum. After all, think about it from the doctor's perspective. There's an elevated PSA. If I do a prostate biopsy, I get paid for my services, and I do the prostate biopsy, meaning I'm going to protect myself from adverse consequence, right? That is less likely to get sued. So doc gets paid, less likely to get sued, patient satisfaction, I'm doing something for you, even if the research doesn't support any benefit. It's tough to bust that momentum. You're talking about breaking into a multi-billion-dollar industry. So back to the origins. Prostate cancer, no fooling, metastatic disease. It's a real thing. Some men are going to die from it. We just don't have the means to intervene early. Ironically, in the setting of prostate health, early intervention causes harm and has no benefit. Better to wait. I know this sounds weird, but it's better to wait, take action to preserve your health on a global level. Remember, cardiovascular protection rules the roost. That's what we're most likely to die from, folks. You get conventional treatment. Here's another thing to avoid. Even if you have metastatic cancer, avoid getting castrated, men, please. They call it androgen deprivation therapy, ADT. Has a nicer ring than castration. But it leads to cognitive impairment, depression, depleted energy, loss of libido, muscle atrophy, bone thinning. It's no way to live. It's no way to live. Vitality, yes. Longevity, absolutely. But you don't have to give up one to get the other. You do all that stuff, the cancer is going to progress anyhow. So the story of prostate cancer continues to be written. In my view, any type of surgical treatment for prostate cancer needs to be considered experimental, and a proper informed consent would include, in bold, this has not been shown to cure your cancer. At least with that, you can make an informed decision. Hey, at the end of the reflection, it's not wrong to get your prostate removed. There are some men that cannot live with the notion that there may be cells lurking in them. I get that. So you can't make a bad decision, even if you choose to get radiation or surgical removal, as long as you've been given reasonable options. And I believe the intellectual medicine option should be right there alongside any other. All right, stay healthy, stay well, protect yourself from the whirlpool that sucks us under when sometimes we get stuck into the momentum of conventional medicine. All right, gang, that's all for now. Thanks for joining me on this podcast. I'll see you next time.